थैंक यू वेरी मच. आज बहुत मज़ा आ रहा है ऑडियंस में बैठ के सुन के, सारा नॉलेज रिफ़्रेश हो रहा है. सो थैंक यू ऑर्गेनाइजिंग कमेटी ऑफ डॉक्टर्सकॉन for giving me the opportunity to talk to all of the primary care and family physicians today. Ladies and gentlemen, जब से हम ज़िंदगी में पैदा होते हैं तो there is a war going on against the pathogens which affect us. Because हम चाहते हैं कि लाइफ की क्वालिटी और क्वांटिटी को इंक्रीज़ करें और ये पैथोजेंस चाहते हैं कि उसको डिक्रीज़ करें. सो दिस वॉर इज़ गोइंग ऑन फॉर सेंचुरीज़. और फिर 1928 में अलेक्जेंडर फ्लेमिंग ने जब पेनिसिलिन डिस्कवर की तो वी थॉट कि दिस इज़ द मैजिक बुलेट, और ये मैजिक बुलेट्स हमें और भी चाहिए जो हमें बीमारियों से बचा सकें. बट सैडली पिल्स हमारे पास आई तो, लेकिन वन बाय वन कुछ किलर डिजीज़ लाइक डिप्थीरिया, टेटनस, स्कारलेट फीवर ये तो चली गई, लेकिन सम ऑफ द डिजीज़ आर स्टिल देयर. And this started showing the failure of the antimicrobials. And viruses, they began to shrug off vaccinations and bacteria grew resistant to bacteria. यही बात है जो अभी डॉक्टर जाहिदा रानी ने भी आपसे की कि antimicrobial resistance develop होना शुरू हो गया. And now on top of that, the new diseases sprang up out of nowhere. And now we have some viruses like Ebola, like chikungunya, like Zika, like COVID recently. But the problems which we began the life with are still there. हमारी जो hygienic conditions हैं, जो water sanitation के issues हैं, they still remain the same. And this is the state of affair not only in Hyderabad, but in all parts of the country. And that is why we are still struggling with older microbes like enteric fever. I'm going to talk to you about the ongoing challenge of enteric fever or typhoid fever, and we will be briefly touching upon what this typhoid fever is, what is the clinical history, how does it present, what are the symptoms, how do we diagnose it, what are the challenges which are now we are facing to handle this problem because of the drug resistance, which is both multi-drug resistance and extensively drug resistance typhoid. What are the treatment options we are left with? What are the guidelines regarding treatment of resistant typhoid? And then I will be briefly telling you about the vaccination of this problem. So typhoid fever is a life-threatening illness which is caused by a bacteria, and the bacteria is known as Salmonella typhi. And it is also known as enteric fever, bilious fever भी कहते हैं, से yellow jack fever भी कहते हैं. ये एक short bacillus है which is motile because it has a flagella, and it is a gram-negative bacteria which causes a multi-system illness, and it is transmitted by ingestion of this via contaminated food or water. And Salmonella जो नाम है, अगर इसकी history में जाएं तो it is named after Daniel Elmer Salmon. In 1850 to 1940, this scientist was an American veterinary pathologist. He described the Salmonella enterica. And this is the famous lady. Her name was Typhoid Mary. She was a cook by profession, and she was working in a mess where she infected 47 people who got sick because of her food, and three were killed. So she left that job and she changed and went to another house where she worked, and then the members of that house also got sick. So she was at that time forced into containment for 2 years, and there was a ban on her employment. But she assumed a false name because she was very passionate about cooking, and then she continued to infect many people and kill many people. And her name was Typhoid Mary, and she was declared the most dangerous woman in America. So later on it was found that she was actually a carrier of typhoid, and she was passing that infection on to everybody where he was cooking food for them. So if we look at the history of typhoid, around 430 to 426 BC, typhoid killed about 1/3 of the population of Athens, but they were not sure whether it was typhoid until 2006, when DNA was discovered and it was determined that this is actually the typhoid bacterium identified, and it was labeled as the killer. Between 2004 to 2005, there was an outbreak in Dominican Republic, and it costed about 42,000 people affected by this bacteria, and 214 people, they lost their lives. So every year, about 11 million typhoid cases are reported around the world, and about 150,000 precious lives are lost to this disease. Without the treatment, the case fatality rate is very high. It is about 10 to 30%. But with treatment, we can decrease it, and it comes down to 1 to 4% if timely diagnosed and managed properly. If we talk about Pakistan, nearly 21 million contracted typhoid annually. These are the figures from 2021. And children are particularly more affected, and there was a large outbreak in Sindh, which was the breaking news for the international media of the extensive drug-resistant typhoid being reported from Pakistan. And 63% of the typhoid cases and about 70% of the deaths which were related to this typhoid were among children who were less than 15 years. So that is when the National Council, which is looking at the different infectious diseases, they started the introduction of the typhoid conjugated vaccine for our children, and now it is the part of the immunization program. So when it was investigated in Punjab, it was seen that people who were suspected of typhoid, about 12% of them suspected typhoid, they were found positive, and almost 93% were drug resistance. So even if we diagnose, it is so much resistant to treatment that we are left with very limited options. Talking about disease, I told you that it is through contaminated food and water. So it enters the body through oral fecal route, enters into your bloodstream, and then travels into your small intestine. And the white cells, they carry the disease then to liver, to spleen, to bone marrow, and where it reproduces, and then it re-enters the bloodstream, and then it invades your biliary system, in your gallbladder, and lymphatic tissues of the bowel. So the transmission of the disease is through contaminated water and food, and patients who are acutely ill with typhoid, they, through the passage of this bacteria into the feces, continue to contaminate the surrounding water, and many of them also become carrier of the disease long term. About 3 to 5%, they continue to harbor this bacteria in their gallbladder and keep on excreting it for the rest of their lives and become the chronic carriers, and this bacteria then contaminates other people. Typhoid fever, I think, आपके पास जो पेरीफ्री से पेशेंट्स आते होंगे, तो आप जब वो बुखार का जिक्र करेंगे तो वो कहेंगे कि टाइफॉइड बुखार है. So this is the only diagnosis which is made by quacks and the periphery unqualified people, that any fever for any reason which is more than 5 to 6 days is typhoid fever. So typhoid fever is actually a febrile illness with the onset of symptoms which ranges from 1 to 3 weeks after ingestion of causative microorganism through contaminated food or water. And majority of the patients, they have abdominal symptoms, like they come with abdominal discomfort, pain, along with fevers and chills. The fever, it starts low and it increases gradually, and it can reach as high as 104. Step ladder pattern of fever bhi isme hum kehte hain. Along with that, patients complain of weakness, fatigue, headache, muscle aches, and white coated tongue. There's loss of appetite and weight loss. There's abdominal discomfort. There can be related diarrhea or constipation. And sometimes there is a particular rash which is seen in these patients, and this rash is known as rose spots. The rash commonly appears in the second week of your illness, and it is more prominent on your trunk, and it is about 2 to 3 millimeter in diameter, pink papular type of rash, which can be easily appreciated in fair-skinned people. In the third week onwards, the patient goes into a complication phase. And the complication phase is mainly in your intestinal tract, which can lead to intestinal hemorrhage and perforation. And with that, the patients can develop signs of shock, drop in temperature, dark or fresh blood in the stool. Rarely it affects your other systems as well, like it can cause pneumonia, it can cause myocarditis, it can affect your kidneys in the form of nephritis, or bones in the form of osteomyelitis. And about 2 to 3%, I told you, become the chronic carriers of gallbladder. Now coming on to the investigations, this is something which is very debatable. For many years now, we've been advocating the use of blood culture and sensitivity for the diagnosis of typhoid fever, because the tests that were previously routinely used, like Vidal test or Typhoid, IgM and IgG, they are obsolete now and no longer recommended anywhere in the world for the diagnosis. I know there is a lot of concern from the family physicians and the general public about the cost of this test and the time duration which is required to establish a diagnosis, but that doesn't mean that we should stop practicing the right guidelines. So the laboratory findings should be confirmed always on a blood culture. Supportive diagnosis you can take from CBC, which shows that patients can have high ESR, they can have anemia, and they can have thrombocytopenia or relative leukopenia. LFTs are generally mildly deranged in these patients, and mild hyponatremia and hypokalemia are also seen. And the other febrile illnesses should be ruled out while making a diagnosis of typhoid. When you diagnose a typhoid, the best is the culture, as I told you. You can culture blood, but there are other cultures like bone marrow, urine, duodenal aspirate, stool you can also do, but routinely and easily available is the blood culture. The blood culture is the gold standard for the diagnosis of typhoid, and it must be sent before starting the empirical therapy in the form of antibiotics. Blood cultures come out to be positive about 50 to 60% of cases, and it is very, very specific. The culture of bone marrow you can also do, but it is painful and routinely we do not do it. Cultures from stool are usually not positive in the early disease, so if you are not getting a diagnosis and the patient is presenting late, then you can get a stool culture. The blood cultures should be sent before starting the empirical treatment, and it is very important that the amount of the culture that you are sending is also to be explained. It must be about 20 ml of blood taken from the sample and inoculated in 2 bottles, both for aerobic and anaerobic cultures. And usually you get a preliminary report in 3-4 days, which tells you that these are gram-negative rods, which are highly suggestive of salmonella in current scenario, but the final report you get after 5 to 7 days. The serological tests are not recommended. I am again and again emphasizing that they have low sensitivity and specificity, and they do not provide any information on antimicrobial activity, so they should not be advised to the patients for diagnosis of enteric fever. Coming on to the very hot and burning topic, which is the resistance of the typhoid fever. Now we classify the typhoid fever according to the drug resistance status. So there are non-resistant typhoid fever, then are multi-drug resistant typhoid fever, and then extensively drug-resistant typhoid fever, or XDR. The non-resistant typhoid fever is the one which is the fever which is caused by Salmonella typhi or paratyphi A, B, or C strains, which are sensitive to first-line and third-generation cephalosporins. So the first-line agents are the chloramphenicol, ampicillin, trimethoprim, sulfamethoxazole, and third-generation cephalosporins are cefixime or ceftriaxone. This may or may not be resistant to second-line drugs, which are fluoroquinolones. The multi-drug resistant typhoid fever are those which are resistant to first-line, but they are sensitive to third-generation cephalosporins. And the resistance to second-line drugs that may be there or may not be there. So I've told you the first-line drugs are chloramphenicol, ampicillin, and trimethoprim sulfamethoxazole. Second-line are fluoroquinolones, and third-generation cephalosporins include ceftriaxone and cefixime. And now we come to the extensively drug-resistant typhoid. Extensively drug-resistant typhoids are those strains which are resistant to all the recommended antibiotics for typhoid fever, including the first line, the second line fluoroquinolones, and the third generation cephalosporins. So when we talk about treatment of these patients, the treatment is generally supportive or empirical or definitive. The supportive treatment is that we give antipyrotics for fever, we advise adequate hydration and rest, and if there is any electrolyte imbalance, we correct it. We give generally a soft and easily palatable diet to the patient if he has abdominal pain or distension or diarrhea or constipation. And if the patient has severe illness, we monitor the blood pressure, sugar levels, electrolytes, hemoglobin, liver functions as indicated. We start the empirical treatment as soon as possible to prevent complications, to prevent the relapse and development of chronic carriers, but we must send a blood culture before starting the empirical treatment. It is usually treated with a single agent as an empirical therapy, and the available agents that we use are cephalosporins. You can give oral cefixime to the patient, and it is 400 milligram twice a day, which is the dose. Or you can give IV ceftriaxone to the patients, which is 1 gram in 24 hours. You can give 2 grams in 24 hours. You can 1 gram BD, or you can give 2 grams OD. And if the initial therapy you've started with an oral agent and the patient is not responding after 5 days of treatment, or if there are any complications that they have developed, you must switch to an injectable therapy. So once the blood culture is available, you can modify your treatment in the light of the sensitivity reports of the antimicrobials, and you should avoid prescribing azithromycin as an empirical therapy for patients. This is the message that I want to give to all of you, that we should reserve for the resistant cases only. The susceptible typhoid or non-resistant typhoid, they can be given either third-generation cephalosporins or trimethoprim sulfamethoxazole, but the definitive treatment should be including the strains. If their strains are sensitive to third-generation cephalosporins, you must give oral or injectable third-generation cephalosporins, and the duration of the treatment should be 14 days. The shorter course is not recommended, and it may lead to relapse of the disease. So at least for 14 days, you should give 2 grams of trioxazone or cefixime 400 milligram twice a day for a period of 14 days. In cases of XDR typhoid, in which the microbes are resistant to all antibiotics which are available, which are first generation, second generation, which are quinolones, and third generations, which are cephalosporins, you discontinue the cephalosporins and then you start with the azithromycin. Azithromycin is dosed according to the body weight. If the weight of the patient is less than 60 kg, you give a loading dose of 1 gram followed by 500 milligrams once a day for 7 to 10 days. But if the weight of the patient is more than 60 kg, you give 1 gram for 7 to 10 days. Now the XDR typhoid, if the patient is unable to take orally and is hemodynamically unstable, or if he is deteriorating despite your treatment or developing any complications, you must admit this patient to a tertiary care hospital, and the choice of antibiotic in this situation would be meropenem. The meropenem is 1 gram dosage 8 hourly for 10 to 14 days. So complicated typhoid you should suspect when the patient develops jaundice, becomes drowsy, his abdominal pain worsens, if there are any signs of intestinal hemorrhage, or patient develops shock or sepsis. And they should be managed in a hospital, tertiary care hospital setting. Talking about prevention, there are 2 types of vaccines which are available for typhoid. These days, a single-dose typhoid conjugated vaccine, TCV, this is being given to the public. More than 6 months of age people, they can be given this. And at least 3 years तक का भी हमारे पास data है, लेकिन revaccination इसकी कब required होगी, this is still under study. So vaccination ये याद रखें कि 100% कोई भी vaccination safe नहीं होती और ना ही effective होती है. So you need still you need other preventive measures, which is hand washing, properly cooking the food, and washing your vegetables and properly cooking them. But vaccination should be given to the high-risk adults and children of 6 months of age and above, all healthcare workers and all food handlers, because they are at higher risk of disseminating the disease. Prevention of the typhoid, you must practice good hygiene, avoid foods and beverages from street vendors because you don't know the hygienic conditions. Avoid drinks with ice unless you are sure about the source from which the water, that ice is used. Eat food that have been properly cooked and ensure that the cooked food is covered to protect from the flies. The typhoid vaccination campaign is now going on in Pakistan. I would end my talk by 3 important key points for your learning. Clean water, sanitation, and hygienic handling of food are key to prevention and control of the enteric fever. Blood culture remains the standard diagnostic tool, and avoid misuse of antibiotics to decrease drug resistance, and propagate the message of typhoid conjugate vaccination in your pediatric population. So don't be a typhoid Mary anymore. Get yourself vaccinated, wash your hands, and cook your food properly. Don't be that dangerous man or woman who was labeled as the most dangerous killer of America. Thank you very much. I would end my talk here by inviting